Thank you, Martha. Good afternoon from Maine, and thank you for joining us for today's Women's Legislative Network webinar focused on cardiovascular health. Before I introduce our speakers, I want to review a few housekeeping items. Today's webinar is a platform for information exchange and engagement. Over the next 60 minutes, we encourage participation through our chat box, so feel free to type your questions and answer any questions in the chat box on your screen. To begin building some comfortability with the chat function and to also learn how is on the line today, I invite you to type in the state from which you are calling now. We will hold a formal Q&A after our presenters are finished presenting. I want to briefly mention the resources. Above the presentation, you will see a couple tabs with one of them labeled Resources. Here you can find and download a PDF version of the PowerPoint as well as some other handouts. Another tab is labeled Speaker, where you can read the bio of today's speakers. You can access these tabs at any time during the presentation. Today's webinar is being recorded and will be available on NCSL's website within the week. Now that housekeeping is out of the way, let's get back to why we're here today. We are excited to learn about the challenges women in particular face when it comes to cardiovascular health. Today's presenters will discuss strategies on how to engage in partnerships that prevent and treat cardiovascular disease, and we'll learn about state policies that focus on cardiovascular health. Joining us today are Dr. Robert Stoenbroek, Medical Director, U.S. Clinical Development and Medical Affairs, Novartis; Selena Gore, Chief Executive Officer, Women Heart, the National Coalition for Women with Heart Disease; and Eric Skinner, Policy Associate, Health Program, National Conference of State Legislators. First up, we have Dr. Stoenbroek. Robert Stoenbroek currently works as a medical director in the Cardio-Renal Metabolism University Medical Center in Amsterdam. He completed his PhD research studying the pathophysiology and treatment of cardiovascular disease with a focus on translating scientific insights into new treatment options. Please see his full bio to learn more about his extensive research and travel. Dr. Stoenbroek, thank you so much for joining us today. The floor is now yours.
Thank you so much, Senator Rosen. Before we get started, I would like to ask you a question, and I'm very interested in your thoughts, so please think about it for a second. I'm curious what you think the #1 cause of death in the United States is. Is it cardiovascular disease? Is it cancer, accidents, diabetes? So think about it for 1 second. I'll show you the answer in a second. Now, obviously, it will not surprise anyone, given the topic for today's conversation, that actually cardiovascular disease is the #1 cause of death, both in the United States and globally. More so than all cancers combined, more than accidents, more than chronic lower respiratory disease. And that is true for both men and women. So what you see here, the left-hand bars represents, the navy blue represents men, and the light blue bar represents females. So you can see that for both males and for females, cardiovascular disease is the leading cause of death. What is very alarming is that cardiovascular disease mortality is actually going up in recent years. So what you see on the slide right now is a graph. On the x-axis, we see year, all the way from 1900 to about 2020. On the y-axis, we see the number of people who have died from cardiovascular disease. And you can see that from 1900 all the way up to about 1970s, cardiovascular disease mortality was going up. And that was a consequence of the fact that therapeutic options at the time were very limited. Now, somewhere in the 1970s, there was an inflection point where cardiovascular disease mortality started going down. And that was obviously a consequence of the fact that we had new additions to our therapeutic armamentarium, including, for example, preventive therapies such as statins, cholesterol-lowering therapies, antihypertensives, and also improvements in interventional cardiology. Very alarmingly, though, in recent years, we have seen a bend in that curve, and we see that cardiovascular disease mortality is increasing once again. So that probably tells us that we have seen the full benefit of all of those treatment innovations that were made in recent decades, and that we need new therapeutic innovations to bend that curve and ensure that cardiovascular disease mortality starts going down again. Now, I wanted to show you a little bit of detail behind the numbers because there are enormous geographic disparities in cardiovascular disease. So what you see here on the left-hand side of the slide is a table with some of the states in the United States with the highest death rate due to cardiovascular disease and some of the states with the lowest death rates due to cardiovascular disease. What you can see is that Mississippi is the state with the highest cardiovascular disease mortality, and Minnesota, right next to it, is the lowest. And one of the very alarming things that you can see in this graph is that actually cardiovascular disease mortality in Mississippi is almost twice that of Minnesota. Now, to double click on those numbers a little bit and looking at it at a slightly lower level, you can also see that even within states there is disparity in care. If you look at the right-hand side of the slide, mortality due to cardiovascular disease is increasing among women under the age of 65 in rural communities, but not in men in rural communities, and also not in women in metro areas. So basically, rural communities are often disproportionately affected by cardiovascular disease, and the fact that mortality among young women in rural areas is increasing is particularly alarming. And the fact that cardiovascular disease mortality in young women is increasing but not in men in rural areas shows us that access to care is probably not a reason for that disparity. And that tells us that the problem is much more complicated than, for example, just access to care. Now, just to look at gender disparities in preventive care for women, we know that from numerous sources that women are less likely to receive adequate treatment or prevention than men. And there are various reasons for that. One of them is that physicians tend to underestimate the risk of cardiovascular disease in women compared to men. And it is partly due to the fact that guideline-recommended risk calculators, which physicians use in order to guide preventive therapy, are known to underestimate cardiovascular disease risk in women. And on top of that, there are also differences in symptoms and presentation of cardiovascular disease between men and women. So the textbook examples of a man with chest pain and tightness around the chest is true for men, but women often have a much more heterogeneous presentation of cardiovascular disease, leading to underdiagnosis and undertreatment. So that's something from a clinical perspective, but even during the drug development process, there are gender disparities. So as you all know, the drug development process typically proceeds from preclinical research to clinical trials, and then ultimately, hopefully, to approval. But we know that even during the clinical trial stage, there is an underrepresentation of women. And we also know that study populations must be representative of patients who may use therapies post-approval, because obviously a drug that has been shown to work in one population does not necessarily also work in another population, and the same is true for gender. So drugs that have been shown to work in men do not necessarily also work in women. Now, why is it that women are underrepresented in clinical trials? Well, there's a variety of reasons. One of them is age limits. So we know that cardiovascular disease occurs in women at a later age on average than in men. Now, if there are limits, age limits, exclusion criteria where older people are excluded from trials, which may be the case in certain trials, then you're going to end up with a population in the trial that is predominantly men, just because women develop cardiovascular disease at an age that may be excluded from a trial. Comorbidities may be another reason. So we know that patients with certain comorbidities are often excluded from clinical trials, and if those comorbidities occur more frequently in women than in men, then you end up with a population in this study that predominantly reflects men. Another important reason is the exclusion criteria that many trials have based on the risk of pregnancy. Now, while that exclusion criteria obviously comes it exists for a good reason, it may inadvertently mean that women are excluded from participation in clinical research. Now, going back to the clinical consequences of cardiovascular disease, we know that every year in the United States, more than 400,000 women die of cardiovascular disease, meaning more than 1,000 every day. And cardiovascular disease does not only have enormous consequences in terms of mortality and death rates, but also due to the consequences of women living with consequences of cardiovascular disease. So we know that approximately 12 million women in the United States live with some form of cardiovascular disease, and therefore are confronted with those consequences of cardiovascular disease each day. Now, what is particularly alarming, if you look at the enormous impact that cardiovascular disease has on our society, is that we know that a substantial proportion of cardiovascular disease could be avoided by addressing key risk factors for cardiovascular disease, such as elevated cholesterol, hypertension, and smoking. Now, if we look at those individual risk factors, it obviously makes sense to target the risk factors that are responsible for the highest degree of cardiovascular disease. And we know that high cholesterol of all risk factors is the risk factor with the highest population attributable risk, so the risk factor that is responsible for most cardiovascular diseases. That is a consequence both of the strong relationship between high cholesterol and cardiovascular disease, as well as a consequence of the fact that high cholesterol is so pervasive in our society. So to zoom in a little bit on that cholesterol, what you see here on the slide is a graph that looks complicated, so let me walk you through it. What we see here on the x-axis is the achieved LDL cholesterol levels, and on the y-axis we see the risk of cardiovascular disease. And what we can see here in this slide is that there's a linear relationship between LDL cholesterol and cardiovascular disease. Without a threshold below which further lowering of LDL cholesterol or bad cholesterol does not further improve cardiovascular outcomes, and without attenuation of that relationship at lower levels. So basically what this graph tells us is that when it comes to LDL cholesterol, bad cholesterol, the lower is better. And that has been shown to be true in both secondary prevention populations, meaning patients who already have cardiovascular disease, as well as in patients who are primary prevention, meaning patients who do not have cardiovascular disease yet. So lowering LDL cholesterol is a very impactful way to prevent cardiovascular disease, both in patients who already have cardiovascular disease, so then you're talking about avoiding a recurrent event, as well as in patients who do not have cardiovascular disease yet. Now, despite all of that evidence, we know that only about 20% of patients with established cardiovascular disease, so patients who are at highest risk of having another event, actually reach their guideline recommended treatment thresholds when it comes to LDL cholesterol. So that means that about 4 in 5 patients in the United States with established cardiovascular disease have elevated LDL cholesterol despite currently available treatment options. And from my perspective, I think there are a couple of reasons for that, but I like to bucket them into physician factors or healthcare professional factors and patient factors. So when we look at the sort of physician reasons for the fact that so many patients are undertreated when it comes to cholesterol, we know that guideline implementation is suboptimal. So what you see here on the slide, these bar charts represent the proportion of patients who are eligible for statin therapy based on their risk profile, and the proportion of patients who actually receive statin therapy. So if you look at the left-hand bars, you see patients with established cardiovascular disease, and on the right-hand side, you see patients who are at risk of cardiovascular disease. The total size of the bar represents the number of people in the United States who should be receiving statin therapy according to the guidelines. And the dark proportion of the bar, the navy blue proportion, represents the number of people who are actually receiving statin therapy. So what you see here is that among both patients with established cardiovascular disease, so the highest risk patients, as well as some patients without cardiovascular disease but who are at risk of cardiovascular disease, a substantial proportion of patients who should be receiving cholesterol-lowering therapy in the form of statins are actually not receiving them. And that is true both for men and for women. So that's it for the physician factors. Now, there are also patient-related factors. We know from numerous studies in the population that a substantial proportion of patients who are treated with cholesterol-lowering therapy or with other therapies for chronic diseases are suboptimally adherent. So what you see here in the pie chart on the right-hand side of the slide is that about 66% of patients with cardiovascular disease are either non-adherent or only partially adherent to their therapy. And obviously, a patient will not benefit from a drug that they don't take. So even if the physician does what they're supposed to do in terms of prescribing the right therapy, obviously you need the patient to take it. And we know that patients struggle to do that. So what I've just described is a couple of the reasons for the fact that the majority of patients with cardiovascular disease still have elevated cholesterol despite available options. So I believe that there are several things that we ought to do in order to reduce the impacts of cardiovascular disease in our society. Now, there are certain things that drug development companies such as Novartis can do. So first, obviously, a company needs to develop therapies with the potential to overcome population health challenges. And one of the things that you could think about is to develop therapies with infrequent dosing regimens that can ultimately allow for healthcare professional administration and therefore, sort of circumvent the problems related to adherence that I just described. So that's just one example. Now, another one is to address barriers to care. And that obviously has to do with access to care. And I think that is actually one of the things where, COVID has obviously, advanced the development of telemedicine. And one example of addressing barriers to care is ensuring that patients have access to care. And you can imagine that for patients who live in rural communities, it may be difficult to receive care in the same way as people who live in metro areas. And I believe that telemedicine is a big opportunity there also to more systematically implement care. There are also certain things that legislators can do. So one of them is to invest in prevention. So we obviously know that a substantial amount of our healthcare resources are spent in secondary prevention from patients who already have cardiovascular disease or other diseases. Now, obviously, if we are able to prevent disease in the first place, we can have an enormous impact. And as we do so, it's also important to consider that one approach may not fit all. So investing in prevention can disproportionately affect one population compared to another. And one of the things to think about is if you promote healthy eating vegetables and things like that. Well, vegetables are more expensive. So if you don't think that through, what might end up happening is that patients who have access to those resources in order to allow them to buy healthy food derive more benefit than patients who do not have access to healthy food. Now, another thing that we can do is to implement the right quality measures. Now, often the quality measures that currently exist are outdated. So one example, as I talked about cholesterol, is that the current quality measures measure the proportion of patients with cardiovascular disease who are treated with statin cholesterol-lowering therapy. But in recent years, we have seen the development of several new cholesterol-lowering therapies, and statins may not be enough for many patients. So rather than measuring whether or not a patient is treated with a statin, it might be more beneficial to measure the proportion of patients who will reach guideline-recommended treatment thresholds. So it's important to update those quality measures as the environment develops. It's also important to ensure in developing those quality measures that disparities in care are addressed. A last thing that legislators can do is to encourage states' health departments to update cardiovascular plans or detailed plans to address cardiovascular disease in our societies. So that's all I wanted to tell you. Thank you, and Senator Rosen, I'm handing it back to you.
Thank you, Doctor, for that informative presentation. Next, we have Selena Gore. Ms. Gore is the Chief Executive Officer of Women Heart, the National Coalition for Women with Heart Disease based in Washington, D.C. Formerly, she was the founding executive director of the Global Alliance for Chronic Diseases. Based at the Wellcome Trust in London, UK, from 2012, she headed up the International Secretariat of the Alliance of 15 of the world's largest research funders focused on implementation research of chronic diseases in low and middle income countries. Please read more about her great work in the Speakers tab. Selena, thank you so much for joining us today. The floor is now yours.
Thank you so much, and good afternoon to you all, and thank you for taking an interest in this extremely important topic. So before I get started, I just wanted to bring greetings from the Women Heart community, and this is a picture of the class of 2019 Women Heart Champions. This is at their graduation at the Mayo Clinic in Rochester, Minnesota. So Women Heart is an organization that educates, supports, and advocates for women all across this country with a mission to improve their lives and make sure that no woman goes through their heart journey by themselves. We are a group that, the group of trained women that seek to provide peer-to-peer support across the country to ensure that women with heart disease and those who are at risk have the resources necessary to fight heart disease and also to live a healthy life, and not just to survive, but to thrive. So as you heard, as Dr. Struikenbrooke talked about, heart disease is the #1 killer of men and women. And I think that that's a really important fact that we don't want to underestimate. So much of the disparity lies in the misperception that heart disease is a man's disease, and clearly that isn't true, but that is going to color so much of what I'm going to talk about today. I want to show you the map form of the distribution of heart disease across the country, and this is focused solely on women over the age of 35. As you can see here, it's Dr. Struikenbrooke is right. The distribution of heart disease is not even, clearly, and the concentration of it is in the southeast quadrant of the U.S. There's also, I think, a really important fact that this misperception is not just held by the public. It's not just held by non-medical people. In fact, this affects the care and treatment of women living with heart disease to the point where, compared to men, women are still less likely to receive even information about cardiovascular risk, which tells you about how even clinicians perceive that relative risk to be. They're less likely to receive treatment or even get started on looking at atherosclerosis as a risk factor. And they're more likely to have a diagnosis of heart failure that is delayed or missed. And in fact, many of our champions have exactly that experience of having a long delayed diagnosis of heart failure. Now, the distribution is not just uneven in terms of geography, it's also uneven in terms of race and ethnicity. And we see here in this figure that the Black community experiences the highest levels of mortality related to heart disease. And so, as we think about programming, as we think about policy making, this is an important feature of how we consider policy responses to the pandemic that is heart disease. Now, we've already talked a little bit about risk factors, but I just sort of want to remind us that there's a whole host of risk factors that are specific to they relate to men as well, but there are some that obviously relate more to women when we talk about all of those associated with pregnancy. And those obviously in turn serve as risk factors for experiencing heart disease during pregnancy. Hypertension, as many of us will know, is one of the most important risk factors of the onset of heart disease. And again, the experience of that risk factor is disproportionate across different race and ethnic groups. And here I think that the big takeaway is even in both men and women, the Black community is the most impacted. And this is true even when they are aware of their hypertension status. It's still much more difficult for them to control their hypertension. And thinking about the pregnant woman, maternal deaths related heart disease related to maternal deaths is it's a very significant problem. In fact, heart disease is the #1 reason for maternity-related deaths. And again, here we see that that distribution is extremely uneven. And again, the heaviest burden of pregnancy-related deaths falls on the Black community in our country. So I wanted to also link heart disease to the current crisis, the current public health crisis that we have been dealing with in 2020. And what I wanted to show here is a snapshot of two different states where they've experienced significant levels of COVID deaths. And one thing that really stood out to me when I was looking at this data from Alabama and from Louisiana is that cardiovascular disease was by far the number one underlying condition related to those who passed away from COVID-19. And so, if we think even before that, in terms of what makes people susceptible, heart disease is certainly at the top of that list. And again, we go back to the distribution across communities of color, across race and ethnicity. We see that, again, the burden is significantly higher in communities of color. Now, I want to do a big about face, because I wanted to make sure to mention that one important caveat in all of this is that with the implementation of policies related to lockdowns and quarantines and social distancing, one negative externality connected to those policies has to do with the significant decreases and declines in doctor's visits across these various conditions. And I don't clearly there are a ton of conditions where individuals are foregoing visits to the doctor or visits to the hospital, but of major importance is those in cardiology. And so even when there are symptoms experienced, even when it comes time to have cholesterol checked, even when they might be experiencing higher levels of blood pressure, they're still not going. And when they do end up going, they're going at a much later stage in their heart disease, which obviously has significant and serious impacts for their health outcomes. So kind of bringing all of this back and relating it to, hopefully some policy recommendations in sort of in the context of how to think about policy making as it connects to heart disease and COVID. It's clear that some populations have a higher level of chronic disease, and those make them more susceptible to negative outcomes in relation to their to a potential COVID diagnosis. But underlying all of that are these significant economic challenges, but also, the broader spectrum of social determinants of health. I think for those of you who are thinking about, various policy responses across a multitude of challenges in each of your states, I would urge you to sort of consider what the public health impact is, or what the health impact is, for each potential policy. And so much of this relates back to ultimately to health outcomes, and in particular heart disease outcomes. So coming back all the way to the beginning to what Women Heart does and why it's so important for organizations like ours to exist. In 2020, we have had to pivot like many organizations out there. And the three things that really have bubbled up that Women Heart has been called to respond to is social isolation being the number one priority. Prior to March of this year, all of our activities had been in person, running support groups, conducting in-hospital patient visits, and conducting community educational events at churches and at health fairs. But clearly that all had to change, and we had to make a hard pivot to making everything virtual, which allowed us to still continue to connect and enable others to connect with each other in terms of implementing virtual platforms. The second is the rise in the large and important discourse around disparities and race and discrimination has required or has called Women Heart really to look at this through the lens of disparities. We have done a lot of work already on this over the last several years, but it just reinforced the idea that is something that will be a fundamental part of our agenda going forward. And then this last bit is I think, much more hopeful in the sense that during this time of real public health challenge, there have also been real advances in the life sciences. And as we just heard from my colleague, that, Women Heart is also here to ensure that these advances are available and are known about, that there is greater awareness about these advances with the populations and among the populations that need those advances the most. And so we play a role in raising that awareness as well. I know that we started at the very top of this presentation saying that, we want to do things, we need to do things in partnership, and that is the only way Women Heart operates, is in partnership. And so I won't go into all of the individual organizations that we work with, but just to say that without our partners, Women Heart couldn't do what it does. We partner with the likes of the Mayo Clinic, as I mentioned, in terms of delivering high quality and rigorous evidence-based training to women with heart disease. We partner with an organization to develop our Women Heart app to connect women one-on-one with heart disease. We partner with Medscape to develop continuing medical education for clinicians so that their awareness is heightened around women and heart disease. And the list goes on, but for an organization like ours, partnerships are really the only way to achieve our mission. So just to summarize, and then also to reinforce what's already been said about what actions state legislators can take, we know that heart disease is the #1 cause of death, and awareness campaigns targeting women is one way to address that. We know that social determinants of health have significant impacts on disparities, and so considering, looking at public health impact assessments across different policy initiatives, and in particular, how those initiatives affect vulnerable populations, I think is key. We know that hospitals are actually a key in reaching those at highest risk for heart disease. And one program that Women Heart has is something called the National Hospital Alliance, where hospitals join us to commit themselves to better being able to address heart disease among women. And then lastly, as we've talked about already, partnerships are key to stemming this burden. And there are organizations that have been fighting this good fight for many, many years, and I would urge you in your states to find those organizations and to partner with them. So I want to stop there. Thank you very much. But also, I start with and I always end with champions. And so this is the class of 2015 Women Heart Champions who I have the great honor of working with every day. Thank you.
Thank you so much, Ms. Gore. I want to take a moment to remind everyone that questions can be inserted into the chat box. Our final speaker this afternoon is Eric Skinner. Eric is a policy associate in NCSL's health program. For the last 4 years, he has worked on legislative health policy and maintained databases related to children's oral health, women's health, and child immunization. He received his Master of Public Health degree from the University of Iowa's College of Public Health's Health Management and Policy Department. Take it away, Eric.
All right. Thank you, Senator Rosen. And hello, everyone. I'm glad to be speaking with you all. Today, I will very quickly walk through a few pieces of legislation that address women's cardiovascular health. So I've divided the legislation on the first two slides into two groups. On this slide, we have bills that indirectly impact cardiovascular health, and the next slide will outline bills that have a more direct effect. So our first example is from Maryland, and it's a telehealth example. Maryland added reimbursement for synchronous and asynchronous telehealth services in Medicaid and telehealth services authorized in a provider's scope of practice. So the reimbursement for telehealth services rapidly expanded in the days and months after the initial stay-at-home orders in March and April. Before the pandemic, you might see components of this example in telehealth bills and policies, so maybe it's just the asynchronous services and maybe it's just in Medicaid. But this example from Maryland provides reimbursement for any telehealth service, whether that's real-time or otherwise, that is covered in Medicaid or permitted under a provider's scope of practice. So that is fairly sweeping in comparison to policies we saw pre-COVID, and we saw many states grow their policies on a similar scale, so we wanted to include this example at the top. Our next example is from Kentucky, and Senate Bill 150 addresses access as opposed to coverage by waiving in-person exam requirements to initiate telehealth services. This allowed people with both urgent and chronic health issues to speak with providers promptly and receive care when needed with minimal risks. And many states have started doing this and other actions to address these administrative barriers to improve access to telehealth services. Another example would be easing eligibility requirements on the provider side. And now we have a couple examples of more direct legislative policies to support cardiovascular health. You'll see Florida's appropriation in House Bill 5001 supports hospitals that provide care in the form of comprehensive stroke and other specialized services to low-income individuals, which makes care more accessible. These hospitals are often in safety net settings and may be the only options for entire communities, and legislatures often work with these facilities to ensure stability both in the healthcare system and the community. And Virginia's House Bill 30 addresses the affordability and accessibility of congestive heart failure services in Medicaid through bundled payments. And a bundled payment is a model of care that links payments to services that patients receive during an episode of care, in this case, congestive heart failure. And like so many public health issues, awareness and education are key in terms of giving individuals the tools they need to prevent or manage heart disease. In 2019, at least 11 state legislatures passed resolutions to promote women's cardiovascular health. Some promote local organizations working in the area, state organizations, or even national initiatives like the American Heart Association's Go Red for Women campaign. And here we have an NCSL Legis brief that we wanted to highlight. It's on this very topic, and the title is A Healthy Rhythm, Addressing Women's Cardiovascular Health. And you can read it by downloading the slides in the resource tab and following the link on the slide. So that is my time. Here's my contact information. Please feel free to reach out with any questions about legislation or this presentation, and thank you all for your attention. I'm going to hand it back to Senator Rosen to keep us moving, and thank you very much.
Thank you very much, Eric. We have a few questions that have already been submitted, but don't forget, if you have a question, please type it in the audience chat box on the left. As a reminder, this webinar is being recorded and will be made available to participants. Unfortunately, we do not have much time left, so any questions not answered on today's webinar will be answered via email. We would like to extend a final thank you to our presenters. We greatly appreciate the expertise each of you were able to provide. Today's webinar was sponsored by Novartis. A big thank you for your continued support of the Women's Legislative Network. And finally, thank you to our attendees for participating in today's webinar. As a reminder, a recording of today's webinar and the presentation slides will be available on NCSL's website within a week. Thank you very much.